Alright, hello everyone. Now in today's lecture we will be looking at Parkinson's disease. So here's what we'll be touching on today. We'll be looking at just a brief introduction to Parkinson's disease. We'll have a look at the main characteristics and symptoms of the illness. Then we'll go on to see how it's consistent with the definition of chronic diseases. Then we'll go on into the epidemiology of Parkinson's. We'll also look at how it's complex. We'll look at rehabilitation programs, and we're also going to look at, as well as critique, a research publication that examines the effectiveness of a particular rehab program. And then, of course, we can't forget our references. Okay, so Parkinson's disease. Parkinson's is a complex, chronic neurodegenerative disease. It's characterized by a failure of bodily movements due to a lack of dopamine. There are currently no cures for Parkinson's disease. However, there are a few programs that focus on rehabilitating patients to reduce their symptoms. Parkinson's is often linked to being a precursor to mental illnesses such as dementia and depression. Now, the main characteristics and symptoms of Parkinson's. Now, Parkinson's results from a decrease of dopamine cells in the brain. So as you can see in the diagram, on the left you see what dopamine cells look like in a normal patient versus what dopamine cells look like in a patient with Parkinson's. Dopamine controls body movements, and the decrease in these cells result in tremors, which is one of the more common symptoms. This means patients with Parkinson's will start shaking, usually in their hands. Patients with Parkinson's generally also experience bradykinesia, which is a condition in which muscle movements become very slow and rigid. Patients will usually become very unstable or unbalanced, so they might have more falls as a result. And patients may also experience freezing gait. That's a condition in which patients develop an inability to move. For example, a patient might not be able to get up from their chair or may feel like their feet are stuck to the floor. Now, aside from symptoms characterized by impaired movement, patients with Parkinson's disease also have symptoms which include fatigue. So patients may constantly feel tired or not have the energy to do daily activities. They may experience masked facial expressions. So usually patients will have a set facial expression they have no control over. Cognitive impairments. Many patients with Parkinson's disease have difficulty swallowing and chewing their foods, as well as speaking. And lastly, patients may have difficulties falling asleep at night, so insomnia. Alright. So how is Parkinson's disease consistent with the definition of chronic disease? Well, Parkinson's is a chronic disease that progresses and persists over a long period of time. This means that its symptoms get worse as time goes on. Parkinson's disease is distinguished by its progressive loss of muscle control, which causes trembling of the limbs and head while at rest. It's also distinguished by slowness, stiffness, and impaired balance. As the symptoms become more severe, individuals with this disorder begin to have problems with talking, walking, or completing other simple tasks. Also, the progression of Parkinson's disease and the extent of impairment depends on each individual. There is no cure, and an individual can live with Parkinson's disease for years. While some individuals become critically disabled, others undergo only minor motor disruptions. So now we'll go on to look into the epidemiology of Parkinson's disease. Parkinson's is the second most common neurodegenerative disorder, according to Statistics Canada. It succeeds Alzheimer's as the number one. In Canada alone, about 55,000 residents aged 18 years or older living in households reported being diagnosed with Parkinson's. In the States, that number is almost 20 times larger, with an estimated 1 million Americans having been diagnosed with the disease. The Parkinson's Disease Foundation reports a diagnosis rate of approximately 60,000 people each year in America. As far as incidence is concerned, Parkinson's is relatively infrequent before the age of 50, and the risk of development only increases from 50 onwards. Speaking of risk, the demographic with the highest risk factor, elderly Caucasian men. I have to say most of us in this class we're safe, we have a long way to go. Risk factors also include a family history of the disease, any previous head injury or trauma, farming activity with pesticide exposure. In terms of public health and treatment, over 60% of people living with Parkinson's reported out-of-pocket expenses according to Stats Canada. So how exactly is Parkinson's disease complex? Well, one way is that it's often accompanied by other complications such as dementia. Dementia comes about in a Parkinson's patient when there is a change in the brain caused by the Parkinson's in a region that plays a major role in movement. As these brain changes begin to spread, they affect the mental functions such as memory, sound, judgments, the ability to pay attention. Dementia can be defined as a severe impairment that interferes with the ability to complete daily tasks. The highest risk for being diagnosed with dementia as a Parkinson's disease patient occurs when the individual is experiencing cases of hallucinations or to control complications. Fortunately, however, dementia is known to only occur in 20% of individuals with Parkinson's disease. Also, with Parkinson's disease, it's known to overlap with degenerative brain disorders that can result in dementia, such as Alzheimer's disease and vascular brain. Now let's go on to rehabilitation strategies. We'll focus primarily on physical therapy. Physical therapy is one of the many rehabilitation strategies utilized to treat symptoms of Parkinson's disease. Using treatment techniques to promote and enable muscle movement, reduce pain, restore function, and prevent disability through examination and physical intervention to manage and improve the quality of life. Physical therapy treats symptoms of rigidity or stiffness, akinesia or lack of movement, poor stability and facial expression due to decreased activation of voluntary muscles, episodes of freezing gait, resting tremor of the arms, legs, hands, jaw, and face, stability or impaired balance or coordination. Physical therapists focus on impairments such as neurologic symptoms, functional limitations with walking and stair climbing, reaching and grasping, as well as disabilities of hobbies, sports, and daily. Physical therapy consists of mobility exercises, gait training either with or without the application of external cues, training of daily activities, relaxation therapy, and breathing exercises. An important goal to physical therapy is the individual and family of the disease process, and the benefits that come with exercise therapy to manage the disease and increase quality of life. Now we're going to look at this study. It's titled The Efficacy of a Physical Therapy for Parkinson's Disease, a randomized control trial. This particular research by Ellis et al. Was conducted in order to investigate the efficacy of group physical therapy intervention in subjects with Parkinson's sites by performing a randomized controlled trial with quality of life as its primary measure of outcome. A total of 68 subjects with typical idiopathic Parkinson's disease participated in this study, and they were split into two different groups. B. Group A received physical therapy and medication therapy for the first 6 weeks, followed by medication therapy only for the second 6 weeks. Group B received the opposite, being medication therapy for the first 6 weeks and then both physical medication therapy for the second 6 weeks. Each subject was required to fall underneath 8 very specific criteria in order to participate within this study. And once 68 individuals were selected, then they were randomly allocated to each group. This was completed or through sealed envelopes that contained the information for which groups the participants were randomly selected to fall under. Each participant was assessed under the SIP-68, a variant of SIP-136, which was originally designed to assess change of the disease. Now, SIP-68 was used to measure the 6 domains of health-related functional status: mobility control, somatic autonomy, psychological autonomy and communication, emotional stability, social behavior, and mobility range. The UPDRS was also used to assess impairments and functional status. Section 1 consists of measuring mentation, behavior, and mood. Section 2 measures ADLs, that is, activities of daily living. And Section 3 consists of measuring the motor system status. Finally, the subject's comfortable walking speed was measured by being asked to walk on the treadmill with support. The rehabilitation program consisted of 12 sessions, each being 1.5 hours. This occurred 2 times a week for 6 weeks and at the same time of day on the same 2 days throughout the entirety of the study. Overall, the aspect they could in regards to the efficacy of physical therapy and medication therapy. By splitting the subjects into 2 groups with opposite methods of treatment, they were able to determine which therapeutic treatment was best for patients with idiopathic Parkinson's disease. It was finally determined that 3 Parkinsons benefit in the short term from physical therapy in addition to their medication therapy. With regards to the functions related to activities of daily living, comfortable walking speed, and quality of life that is related to mobility. Now we're going to dive right into analysis. Criterion 1. Was the eligibility criteria specified? Yes. The eligibility criteria was specified as the subjects had to meet 8 specific inclusion criteria to even be included in the study, as identified on page 620. Criterion 2. Were the subjects randomly allocated to group? Yes, they were. The subjects were randomly allocated as identified under the study design heading on page 627. 8 subjects were randomly allocated at a time by data collection, treatment implementation, or data analysis. They were handed out in the form of block randomization as envelopes, with 4 being group A and 4 being group B. Criterion 3. Was the allocation? It was. The allocation was concealed as each participant received a sealed envelope detailing which group they were in, as identified on page 627 under the Study Designs heading. Criteria 4. The groups were similar at baseline regarding the most important. Yes, the groups were similar at baseline due to the intensive criteria requirements in order to participate in the study. Criterion 5. Were all the subjects blinded? No, the subjects were not blinded, as they were all required to sign an informed in order to participate in the study, as identified under the Participants heading on page 627. Now, Criterion 6. Was there blinding of all the therapists who administered the therapy? No. The therapists could not have been blind, as each step in regards to the actual physical therapy, medical therapy, or both. Criterion 7. Were all the assessors who measured at least one key outcome blinded? Yes, there was blinding of all the assessors, as there was a sentence on rehabilitation program heading that states that the physical therapists involved in performing the intervention were not involved in conducting any assessments. This means that the assessors were blind and not involved in the therapy itself. Measures of one key outcome, 85% of the subjects initially allocated to the groups. That's criterion 8. No, this is not true, as we have determined that if only 57 out of 68 subjects attended the final follow-up treatment sessions, then there's no way for the measures of at least one key outcome, as identified on page 627 under figure 1. 57 out of 68 actually came out to be 83.8, which was rather close, but unfortunately did not meet the requirements for this Pedro scale subheading. All subjects for whom outcome or control condition as allocated, or where this was not the case, data for at least one key outcome was analyzed by intention to treat. Now this criterion 9, this was true as each group had individuals whose outcome the treatment they were allocated to. This is also an RCT of the efficacy of physical therapy on Parkinson's disease patients. So if there was no treatment, if there was no intention to treat them, then this would not be a very strong article. Criterion 10 of between group statistical comparisons are reported for at least one key outcome. Yes, this is true as identified through the p-values on table 2, group comparisons, on page 629. And lastly, criterion 11, the study provides both point measures for at least one key outcome. Yes, this is true as identified under the results heading on pages 628 to 630 through the very many comparisons between group A and group B. Okay, and here are your reference purposes. And this is the end of today's lecture.